I've been struck at how quiet it's been. You may hear a child or dogs on my end, but I'll quickly introduce myself and then have my colleague Suresh introduce himself. I'm Mark Sendak, been at Duke for a decade and have been working full-time on COVID for essentially the last 3 to 4 months, and privileged to be here. Suresh?
Good morning to all. Thank you for the opportunity to present here. I've been at Duke for about 10 years, working on a variety of activities related to strategy and innovation. Mark, proceed.
Perfect. So we work at the Duke Institute for Health Innovation, and we were a group started in 2013, and every year we work on about 10 to 12 different projects, and these are typically priorities that are selected by a combination of health system leaders as well as frontline staff that propose solutions to the problems that they face providing care to patients in our community. So over the last 7 years, we've done projects spanning the inpatient setting, outpatient setting, and then quite a few projects that are direct to patient and community members. So we've built technology infrastructure to support these efforts, training programs to build the workforce to be able to design and implement and evaluate these types of technologies. And it was really with this background that we were called into a meeting on March 5th. So the division chief for critical care, a woman named Raquel Bartz, who we'd worked with on flu reporting to the CDC a few years back, reached out to us for a 30-minute call. And it was on a Thursday after one of our team meetings. And the question was, how can we leverage the technologies that DHI has built over the years to prepare for COVID? So at that time, there was nothing going on the East Coast. We hadn't seen a case yet. It was largely confined to a skilled nursing facility outbreak in the state of Washington. So we started 2 work streams after that meeting. One was around surveillance. So we had not yet seen a COVID case, but we immediately started building out a surveillance system for influenza-like illness. So we were prepared before we had a COVID case to be able to monitor any surges in influenza-like illness that we were not able to confirm or attribute to non-COVID viruses. And then when COVID did start hitting our local region, we had our first cases on March 13th. We had the system up and running and we're counting cases day to day as well as symptomatic visits across our healthcare system. Where we are today is we have real-time dashboards that have been fully operationalized. These update every 10 minutes. We're looking at cases in the ICUs, cases on ECMO, ventilators, as well as bed level dashboards to show you across all of our units, how many beds do we have open, how many beds do we have COVID patients on ventilators or ECMO. So this part of the work stream has been operationalized, is used by our senior leadership in the healthcare system. In parallel to this piece, there was a different question that was nagging at us. And that was, how do we keep people safe outside of our healthcare facilities? So even in early March, we knew from data in other countries that most COVID infections would be mildly symptomatic or asymptomatic, and people could manage at home, but they would need help managing at home. And that was the problem that the Pandemic Response Network was born out of. So the 2 challenges we were trying to tackle were the lack of localized and timely monitoring of symptoms. We started with symptoms because capabilities for testing were so variable. Now we have daily questions about COVID testing and social needs. We're introducing the ones around social needs. And the second piece was the inability to provide personalized triaging of care. So day to day, there's a lot of people in our community trying to answer the question, am I safe at home today? Or do I need to seek medical attention or go to a hospital? And whether you're a private or public entity, we've seen the devastation across industries. It's hard to know what resources you need without understanding the burden of disease and proportion of individuals who need escalation of care. And I want to mention too, we launched this expecting to be involved in managing it for the next 2 years. So our vision was, how do we empower individuals and communities across the United States to monitor medical and social needs and support the escalation of care and triaging? So where we started was launching a longitudinal symptom support program. We provide up-to-date materials. We have an interdisciplinary team of experts that we are constantly meeting with and reviewing and updating the materials. We're the only program in the country that does telephone follow-up to anybody anywhere who may need immediate medical attention. And every week we share data publicly and with organizational partners to make sure that they have the information they need to make their policy decisions. So we started launching a program, Community Health Watch. We joke that even though Suresh and I work for an innovation team, we started doing something that was not all that innovative. So the Centers for Disease Control put out their care kit in February. State health departments followed suit shortly after with paper forms for symptom monitoring. So we started with the paper forms. We got our interdisciplinary team of experts together, created a unified set of protocols. We have fully scripted telephone follow-up. We have a physician overseeing the team of triage nurses who are making the follow-up. And while we started with COVID-19, we expected that over time, we're changing the way that people access services and we can provide more services for other medical or social needs. We're trying to reach entire communities. There's no geographic or age restrictions. A really important question we faced early on was, are you building something for Duke Health patients or for people who are not Duke Health patients? And what we knew up front was that just because someone's not a Duke Health patient today doesn't mean that they won't need a Duke Health ventilator tomorrow. So we made the explicit decision that this would be open to anybody. Anybody can go to a website and consent to submit their information, and we will monitor their symptoms and provide follow-up as needed. We're very much trying to reach high-risk subgroups, and we've had the program available in Spanish for the last 3 weeks. This is what the participant experience looks like. At enrollment, you enter your baseline symptoms, your risk factors for severe disease. I want to make abundantly clear that this is not about bringing people to Duke for their healthcare. So this is about escalating care where people get their care. So we get medical provider information up front, where you get primary care, what hospital you would go to in case of an emergency, and we present you that information at any point during the symptom monitoring period. We also require an emergency contact because we fully expect that there's going to be folks who end up in the hospital and we need a way to follow up. So from there, you join a hybrid high touch, low touch. We initially launched with a high touch twice a day for 28-day period program, but we found that many of our participants, when they finished 28 days, they actually re-enrolled. Our program is focused on safety, so we provide real-time feedback to anybody anywhere on the need to seek immediate medical attention. If anyone registers a positive COVID-19 test, we tell them to notify their close contacts, and then we do telephone follow-up for severe symptoms, no response in 24 hours or no response in 48 hours. 3.5 months in, this continues to be the only program in the United States that does telephone follow-up for anyone for severe symptoms and is fully available in Spanish. What we found so far, so this week we actually cracked 5,000 participants. So what we found so far is that most people participating are not symptomatic and are not infectious. People are scared, and they just want to participate in a program that provides them some type of structured support to monitor their symptoms. Once people join, we have almost 100% retention rates, and we only have to call less than 2% of our participants day to day for having severe symptoms. We initially launched thinking this would be a regional program, but within a week, there was a woman from Montana who reached out to me asking if she was eligible because she had no testing within 100 miles, so she joined. And we're actually in regular contact now with a grocery store clerk in Florida whose employer doesn't require customers to wear masks. We've sent her flyers and she's distributing this to her coworkers. So while things look peachy and we're growing, we add about 150 to 200 participants a day, there's still very large gaps that what we're seeing of the people we're reaching. So on the left-hand side, you can see the digital divide as we're trying to reach people over the age of 80. And then in terms of race and ethnicity, it's been very difficult to reach communities. So this goes back to a lot of the comments brought up earlier today around what do we do when we're trying to provide support to historically marginalized communities. We need to be partnering with them. So not only is this a research concept, this is actually also has strong roots in innovation theory as well. So the process is called customer development, to test hypotheses of what should work, what should not work, and then rapidly iterate on the way that we're developing our technology solutions and supportive services for these historically marginalized communities. And so it hasn't just been us going out and talking with people. Most of the last 3 months, I've been on Zoom meeting with various folks in the local region as well as across the country. But we've had the privilege of working with an expert team of designers from IDEO.org, the nonprofit branch of the world-renowned IDEO. And I do have to share that their findings are discomforting. So here's a few quotes from a report that we're going to be putting out in the near future. But essentially that focusing on symptoms and contact tracing without recognizing the other needs that communities have right now amongst the health and economic devastation is short-sighted, and that we really have to be working to build trust, empowering communities. And so this is the work that we're doing. We're going to be pivoting and releasing an updated version of our program in the near future. Here's the list of partners that we have to date. We have been working very closely with Unite Us and integrating NC Care 360 into our workflows to do social service screening. We've had the privilege of working with Georgina Dukes, who actually was at Duke, so it's been nice to bridge, as well as several state programs and state associations. So it's a privilege to be here. I think this is very challenging work in a very hard political environment, and we have a lot of work to do to really be reaching the people who need support. So thank you.
Thank you very much, Mark and Suresh. I think lots of very important work.